We're great. Have you ever felt lost in the medical system? You ever felt like you were just kind of a number and kind of confused on where to go? Navigating the medical system is not simple. And the older we get, or the more complicated our healthcare gets, the more complicated that becomes. Today, we're going to talk about kind of the navigation of that system and hopefully give you some tools on how you can maximize your opportunities there, and also figure out how to navigate that, especially as we're getting closer to our end of life. But before we get into it, I want to introduce somebody. This is Kay Montgomery. She's an 83-year-old great-grandmother. She has a few health problems, but has been doing really well. She's been living independently for about 15 years after her husband passed by herself, and managing all of her own finances and everything else. She's been doing great. Now, she has been going to the doctor periodically and coordinating all of that. And she started noticing that her legs were swelling. And she knew she had heart failure, and this was something that could happen. So she went in to see her primary care doc. Now, the advantage of a primary care doc is somebody who's going to hopefully have a longitudinal relationship with you. Someone that had been taking care of Kay for like 20 years. He knows all of her medications. He knows when she's been in and out of the hospital. He or she has also talked to her about what kind of expectations she has, especially as she's getting older. The skill sets in a primary care clinic are really going to be things that we can do planning long-term. We can definitely do acute care in primary care, but a lot of it is going to be the long-term management, focusing generally on what can we do to help the body last its longest ability. The other things that it can do, you can order outpatient labs, which take 24 to 72 hours to come back, imaging that takes 24 to 72 hours. So very little acute emergent care happens in the clinic. So if you're not in an emergent situation, if you've seen, this is a good spot. Urgent cares fall into this where they can do a little more than that on site, but generally have the same kind of limitations. So her primary care provider evaluator said, I think you might be having a little bit of heart failure. Let's get some labs and let's try increasing your water pill, your Lasix, and seeing if that helps you out. So Kay went home, she did that. And the next day she actually woke up at about 5 a.m. really short of breath. So she couldn't breathe, couldn't catch her breath. She called the ambulance and they took her to the hospital. And they took her to the emergency room. Now, the emergency room is acute care right now. And everything we're doing in the ER, the goal is to fix something that's potentially going to end your life. Now, the skill set in the emergency room, we can get labs within an hour often. We can do imaging within 15 minutes. There's a lot of things that are amazing in the ER. Downsides, oftentimes there's a long wait, depending on how sick you are. There's also very little access to your record. And they may not know your medications, they may not know your prior imaging, and they may not have any of that background information that hopefully your primary care provider would have. So they have to make a lot of assumptions, and a lot of information is provided by the person coming in. So for Kay in her 80s, trying to remember all of her details becomes very hard, especially when somebody's sick and ill, trying to communicate that effectively and trying to help be an advocate for yourself. However, in the ER, they looked at her and they said, you know what? We think you're having a lung problem, so maybe COPD or some kind of asthma exacerbation. We think you are probably having heart failure issues, and we think you're probably a little anemic. So all of these things came together. But fortunately, they were able to give her some medication. She was able to feel better. She stabilized and said, you know what, you're okay. You can go home. So they were able to get her into a spot where she went home. But they said, you know what you should do? Follow up with your primary care provider. So she goes back to her doctor. Now, the limitation here is that communication from what happens in the ER, from the patient's perspective, has some challenges and may not have all the pieces that the doctor was concerned about. Getting the record from the ER quickly within 48 hours, which is generally when they want somebody that was super sick to follow up, can be very challenging. So the doctor is often working with limited information on where we are at the follow-up on that ER visit. That becomes a real challenge. However, we'll make some assumptions that we're able to see the labs. Maybe it was in the same electronic medical record, and he was able to see a number of things. He said, you know what? There's so many things wrong. We need to get some specialists involved. And he started doing the ologist challenge, and he started referring out. She was anemic, so he sent her, which means she had low blood, sent her to the hematologist. Well, and she had an acute kidney injury too, so he sent her to the nephrologist. And she was having heart failure, so he sent her to the cardiologist. And because she's been confused, she went to the nephrologist. And, oh, there's the neurologist for the confusion. Let's see, cardiologist as well, nephrologist, She was anemic as well, so they want to say, where is it coming from? Send it to the gastroenterologist. Maybe she needs a colonoscopy or something else to try to find out. Her vision was bad. She has diabetes, hasn't seen the eye doc, so let's put the ophthalmologist on there as well. And there's the hematologist. Now, the challenge when you go to all these doctors, especially if you go to them in a short span of time, is that you may not be able to have the notes from each provider. And each provider has a different goal. A specialist has a knowledge set that's very, very extensive on a very narrow topic, which is super useful, especially when you're trying to figure out why someone's heart isn't beating right or why somebody's bleeding from their gut, right? You want the specialist to help be able to manage that, but they may not be thinking about the full picture. The primary care provider is going to try to bring that together and put it all together, but when you're seeing a lot of people at the same time, this can become very dangerous because the nephrologist is going to say, we're going to do everything to protect the kidneys, right? Let's avoid any medications that might harm the kidneys. But the cardiologist might say, you know what? She has stents. She probably needs to be on aspirin and Plavix. But then the gastroenterologist is going to say, well, those might be causing her to bleed. Let's stop those medications. And we should start something else. The hematologist might be, well, you know, we need to be on iron. And now she's constipated. Now she goes back to the gastroenterologist and says, I can't go to the bathroom, right? So all these other people are starting to make multiple orders, trying to help this patient be healthier, but may not be seeing the whole picture. And this becomes very dangerous, especially as you have more and more cooks in the kitchen. And we're going to talk about some techniques that can help minimize that risk and get everybody on the same page. Oh yeah, and she couldn't breathe, so she saw the pulmonologist as well, who put her on steroids. Well, after seeing all of her doctors, she woke up and she wasn't breathing well again. She goes back to the ER. This time, Kay is in distress. She can't breathe. She actually needs oxygen support. They put her on a machine called a BiPAP, where they actually breathe for her, but from the outside. And it's a system that can be very uncomfortable, but when you're in a situation where you can't breathe, it can be life-saving. Well, not only that, she's also anemic, and it's even more than when she was there before. And she's really sick. So they admit her to the ICU. They have blood hanging. She's tired. She's worn out. She hasn't been able to breathe for a day or so. And all the specialists that are in the hospital are now coming by to check on her. Now, the ICU is a unique spot. When you're admitted to the hospital, there's two different levels. There's the inpatient setting, which is generally if somebody could do okay overnight without being checked on. That is where you would go for inpatient. Now, if you need to be checked on overnight, ideally, I mean, even if you need to be checked on every hour or every 15 minutes, that's the ICU. This is the intensive care unit. It's where we do our critical care in the hospitals. And this is going to be where we're taking care of our sickest patients. So Kay was in this situation, and she wasn't getting better. And the family was there, and they were trying to understand what Kay wanted. And she said that she never wanted to be intubated, which intubated is life support. So they had that as kind of like, that's our end stop, but where do we go from here? What are we doing? So they're talking with the doctors and trying to figure that piece out. And the doctors recognize that Kay's progression is getting to a spot where they don't think she's going to turn around, especially if she doesn't want to be intubated. At this time, they decided to consult hospice. Now, hospice has many different roles. In the hospital, it can be transitioning to what we would call comfort care, where our focus has very different goals, where we're trying to get her to a spot where she's able to be around her family, be able to pass comfortably, and other pieces there. But I'm going to talk about that again in a moment. At the end of it, she did end up passing. They withdrew care. Her family was able to be there with her. And Kay Montgomery actually used to be Kay Odom. And Kay Odom was my grandmother. And she's the reason that I do this talk, because the care that she got wasn't bad, but there are things that we could have done that were different and could have given her a different experience. And the whole reason that I want to have this talk is that we're going to talk about what we could have done that would have been different in Kay's case, that hopefully will give you the tools that'll help you with those transitions, be able to think about it a little bit differently. One of the things in reflection that would have been good when she started seeing all these specialists and she was having all these other pieces is, what were her actual goals that she wanted, right? Were we at a spot where it was time to start thinking about how comfortable she was and what we could do to maximize that? Or were we at a spot that we were still working on, like, how far do we expect someone to live? And at 83, depending on how someone's doing, it could be either way. And those questions could have been asked by our primary care provider, could have been asked in the ER, could have been asked anywhere along the line. And there's even a service called palliative care, where we have the conversation, and in an ideal world, this would be with somebody that has a long-term relationship with you, right? So your primary care provider would be the perfect person to do this, but sometimes that's not feasible. And there's even services that are dedicated entirely to setting goals, and that would be the palliative care team. Some hospice programs, like at Hospice North Idaho, have that dedicated. There are other people that can do that as well. And what they do is they help set the goals. What are we looking long-term? And does your care currently meet those needs? This question, I think, would have been phenomenal for Kay 6 months before we ever got to this spot. The other piece, when you get to the spot where we know that we may have less than 6 months to go, is should we transition to something like hospice, where you know things are getting worse, but it doesn't need to be 1 hour before she passes. Hospice used 1 hour before they pass isn't wrong. It is a reasonable perspective to try to change somebody's course while they're in the hospital. However, it has so much more potential to give people the resources to have that death of what they expect that to be and where they want that to happen. And I think that would have been the really important question for her, moving where she was at, and was going to the hospital that in time the right answer? I don't know. She turned around so many times to the hospital that we thought this might be another one like she had. But those questions could have been asked earlier. So when it was case time, our family was there, and she was able to pass with everyone around her peacefully, and she was able to be comfortable. And it was actually a good experience for her, and our family had good closure. But like I said, there are so many things that we could have been different. And what I would like to challenge you to do is be prepared. And what does that mean? There's a couple different pieces, especially as our medications and our care become so more complicated. It's important to be able to have some kind of binder that you take with you to each encounter. And that way you have a current medication list. So when she went to see the nephrologist, he said, oh, we need to add this medication. Oh, I'm already on it, right? And you can prevent duplications. Or the gastroenterologist is concerned about this medication, right? And then you can make these lists of questions that you want to ask your providers. And that way they can see which medications have been added and which ones have been taken off. And then when you go back to see your primary care provider, you can update that as well, because it's really complicated when you get 5 or 6 different people in the system trying to do that. Now, that can also be incredibly valuable anytime you go to the ER, having that information. The other things that are really useful in it is your past medical history, right? She had heart failure, diabetes, she had kidney disease, she had all kinds of things, and having recent labs, because that information can make life or death decisions for you while you're in the hospital. Is her kidney function acutely worse? Or is this where she usually runs? Is her heart failure acutely worse? Or is this where she usually runs? And those sorts of pieces can really help manage somebody very differently in the ER or in clinic or at any of the specialists. So if you can have that binder with that information, it would be really valuable. And this would even be something that'd be worth meeting with your primary care doc about once you have it set up, just for them to even go through it. Because this could be very valuable and life-saving even. Now, in medicine, we have this really bad habit of using something called doctorese. And this is the language of doctors. We go to medical school for a long time. And while we're there, one of the main jobs is learning how to communicate very efficiently and very effectively with our colleagues. However, that entire language we learn doesn't translate well. And many people will slip and not use lay terms or normal terms to talk about the care when we're communicating things to our patients. And it's not on purpose. It's oftentimes just people being busy and not thinking about it. If there's ever a spot where you're like, Doc, I don't know what an AKI is, or Doc, what do you mean ejection fraction? There's so many different words that we use in medicine that we just don't even think about by accident. And it's not intentionally doing this, but if we do that, take a moment, just say, excuse me, can you explain that, please? And you just saying that, it will never offend a doctor, or it should never offend any healthcare professional while you say that, is that helps us know, 1, that you're paying attention, 2, you care, and 3, what we're saying is actually getting through to you and helping you understand your own health, because that is really the most important part. We see you for 15 minutes every 3 months. You have to take care of yourself the rest of the time. So that's really important. And one of those doctorese that gets thrown around all the time is code status. Code status, you'll come into the ER, and if you're being admitted, we're going to ask, what is your code status? Depending on who you're talking to, we might go into a little more depth about that. But between full code, DNR, DNI, and comfort care have drastically different approaches on how we help take care of somebody while we're in the hospital. And what we're going to do is we're going to actually break into small groups and talk about each of these to kind of explain what that is and how that can be effectively communicated to represent what your goals of care are. So thank you for your time, and we're going to break into our groups now.